Allora, direi che riprendiamo. Oggi viaggiamo con un po' di ritardo. Viaggiamo con un bel po' di ritardo, tipo mezz'ora. Allora, dunque, adesso ieri vi anticipavo di Luc Thomas. Luc Thomas è il direttore della clinica dermatologica di Lione, giovane, perché i concetti non è che i direttori sono sempre anziani, abbiamo anche dei direttori giovani. E praticamente nella clinica loro si occupano quasi esclusivamente di dermatooncologia, quindi fanno vedono tantissimi pazienti, ma proprio l'argomento che Luc ha sempre affrontato è stato quello delle lesioni ungueali, quindi dei tumori ungueali in generale. E loro già alcuni anni fa hanno studiato il melanoma e i neoungueali e quindi oggi abbiamo dei criteri che possiamo utilizzare in questo ambito, ma poi loro gestiscono tutta la problematica dell'unghia, che come sappiamo bene non è facilissima, no? Anche dal punto di vista della biopsia, dell'escisione, eccetera. Per cui lui farà una parte diciamo diagnostica, ma anche una parte di gestione dell'unghia. Ok? E Luc, it's up to you. Thank you.
Is this working? Can you hear me? Good. Again, I'm sorry, my Italian is not good, so I will speak English, since French is probably different for you. I must say that we moved from this old facility to a new one outside the city. So if anyone wants to visit now, it's not in the center of Lyon, but outside. I must show my conflict of interest. I have two. This book of Dermoscopia, but it's only in French, Polish, and Portuguese, so I don't think there is any conflict with the Italian audience. But maybe you heard of this book, and I'm also the co-author, and there is an Italian version, and I make a lot of money with this book. I'm a full-time employee of the French Ministry of Education and Research. I have no private practice and no financial relationship with industry. The funding of our research is given by a non-profit association, and the funds are kept by either my hospital or my university. So this is the usual image you have of melanoma on acral sites, and especially in the nail. But we must say that this is a very late event. In most cases, the patient starts with the pigmentation of the nail, and this image, although it's known that it could be melanoma, is often treated as fungal infection or other disease. And in this paper reviewing 121 cases of acral melanomas, we found that 70% of patients with ungual melanoma had 1, 2, or 3 lines of antifungal treatment prior considering the diagnosis of melanoma. And this is very wrong, because usually this image does not correspond to the usual image of fungal infection. So in our view, it's important to make the precise diagnosis of these lines that we call melanonychia striata, or longitudinal nail pigmentation. But having said that, we have a big problem, because longitudinal nail pigmentation can correspond to many different diagnoses. This is a nevus, and this is melanoma. Of course, there are some differences, and I will come later to these differences, but these are the most important diagnoses. And if you want to not miss this one, you have to consider melanoma as the first-rank differential diagnosis in case of longitudinal pigmentation. But the story is not stopped there. You have many other diagnoses. This is ethnic type pigmentation. This is subungual hemorrhage, very common. This is lentigginosis, Logier-Hutziker disease. This is drug-induced pigmentation. This is fungal infection. This is chronic trauma-induced pigmentation due to the abuse of this finger by this one in very narrow shoes. This is Bowen's disease, and it's also pigmented. And this is onychomatricoma, an often pigmented tumor. So many phases of melanonychia striata, many differential diagnoses. Melanoma is, with squamous cell carcinoma, the two threats for the patients, but we need to consider all these diagnoses. And if you want to know the exact story, you will have to do this to the patient. And if you do this to someone, he will forever remember your name. Forever. So this is very painful, and it's very important to select the patient to whom we have to perform such a surgery. But remember that what we see on the nail plate are indirect symptoms because the disease is located in the nail matrix, and of course you cannot see the nail matrix. So you see pigments coming from the nail matrix, but with different patterns that may reflect the original disease, but that are not the original disease. And if you do this surgery, then you can induce scars. So if you have a guitar player, for example, it's very bad to have nails like that. This is very bad surgery, but it's unavoidable. If you take more than 3 millimeters of the nail matrix, of the proximal matrix, then you will create this kind of scar. This is larger, and of course, in some cases, you have to make a complete excision of the nail unit. For that reason, because differential diagnosis is difficult, and it's the whole story of dermatology, differential diagnosis, we created a clinical algorithm. And some symptoms are more in favor of a malignant tumor, and some symptoms are more in favor of a benign lesion. So what is usually benign is when the pigmentation is acquired during childhood. It's very unlikely that a pigmented band on the nail in a child could be melanoma, even though there are cases, but they are debatable in my view. It's also a good sign when you see multiple bands on multiple fingers or toes. Usually, melanoma is single. If you see many bands on many fingers, then it's better. Of course, like usual, cancer is changing over time, and if the lesion is stable, then it's a good sign. But you have to remember that acral lentiginous melanoma is a slowly growing disease. In other words, if a patient says that the lesion was present 20 years earlier, it does not rule out the diagnosis of melanoma. It has to be present for a long time. It could be present for a long time, but it must change over time. If it changes, then it could be melanoma. When you have another good explanation, for example, the patient takes a drug that induces pigmentation, or the patients come from an ethnic group in which it's very common to see nail pigmentation, this is also a good sign. And of course, if there is no periungual involvement. On the opposite, if the lesion has the onset during adulthood, if it's monodactylic, if it changes over time, if there is some periungual involvement that we call Hutchinson sign, if it is polychromic, if it is triangular shaped but only in adults, and if there are changes of the nail plate, erosion of the nail plate, fracture of the nail plate, these are very bad signs. We will see that in images. So this is onset during childhood. This is a newborn infant, and this lesion was present since birth, so this is not a bad sign. This is a polydactylic lesion in a patient with dark skin. This is a good other explanation, and it's also rather benign. But on the opposite, if you have polychromia, if you have periungual involvement, If you have changes of the nail plate, then it's rather malignant. If it changes over time, you see this lesion changed after 18 months. Of course, the lesion was stable, was present for a long time, but this change is significant. This new band here in an adult is significant. If it's triangular shaped, it means that it's enlarging faster than the nail is growing, then it's also a bad sign in an adult. So to better select the patient to be submitted to biopsy, we try to establish dermoscopy rules to make the diagnosis of melanoma and to make the other diagnosis. So this was published in 2002. And of course, this nice figure you know for the rest of the skin does not apply to the nail. We know many things from dermoscopy that could be applied also to nail pigmentation, but often they are very late symptoms. For example, linear and irregular vessels, these milky areas, these hairpin vessels in a squamous cell carcinoma, these symptoms are common with the nail and with other locations. But it's not very common. And when you see a patient with a pigmented band, you have to know a few things. First, you have to recognize blood underneath the nail plate. Blood always has this roundish shape at the proximal origin and this somewhat filamentous aspect at the distal origin. The color is not important. It changes over time. If it's a fresh subungual hemorrhage, it's purple or even red or black. And if it's old, it could be brown, just brown like a nevus. So the color is not important. The shape only is important. So this is the proximal edge. This is the distal edge. You have roundish proximal aspect and somewhat filamentous distal aspect, and the color is not important. You see it's purple here, it's blue here, it's changing over time. Blood spots are in favor of subungual hemorrhage, but you have to remember that cancer is bleeding. And if cancer is bleeding, it's normal to see hemorrhages. And if you have a bleeding cancer, especially if the patient takes an anticoagulation drug, then you will see nothing through blood. So you have to make sure that everything goes away and there is nothing hidden underneath this blood deposit. But you see that in 60% of amelanotic melanomas and in 1/4 of squamous cell carcinoma, we found also these hemorrhages.